Okay, the second half of the presentation will focus on fundamentals, study designs and their fundamental designs and interpretation. And the way we're going to do the second half is to focus in this particular way, first starting with validity, bias, and confounding, go through clinical study designs, clinical trials and interpretation, talk about summary measures of effect, and then a couple miscellaneous topics. There's kind of miscellaneous topics at the end and kind of thrown in through, just because I think you at least need to, again, recognize some of these as we discussed in the first session. We've talked about what you need to know. Again, this is kind of the second half of that 25% that we've discussed. Let's start with validity. First, two important types of validity, internal validity and external validity. So when a group of you are sitting around a lunch table in a journal club talking about the plus and minuses of a study, for the most part, the things that you're describing or discussing are the internal validity of that study. That is, validity within the confines of the study methods. Is the study design appropriate? Does it actually test or measure what it purports? Is the conclusion that's drawn by the investigators appropriate? Contrast that with external validity, which of course is no less important. In this case, can I apply this study to my patient population that I take care of? So, do the results of this study apply to my health system? So, internal validity within the confines of the design. External validity, is this representative of the population that I'm taking care of? Bias in study design. Bias is defined as a systemic, non-random variation in study methodology or conductance that introduces error in interpretation. Selection bias, some examples of bias. Selection bias arises from bias in the selection of subjects. Okay, and as we go through, we'll talk about a couple of examples of this particular type of bias. Observational bias or informational bias could be bias in recall. If we're asking someone a question, perhaps if something happened to them 10 years ago, they may not have a very effective means for recalling that. Interviewer bias. If we're conducting a study in which we have 3 or 4 different people interviewing study subjects, we have to make sure as best we can that those interviewers are functioning in a very similar manner, they're asking questions in the same way, they're leading subjects in the same way, such that we don't introduce bias. We could talk about bias for 90 minutes. You guys would be asleep in probably 5 minutes. And I would have exhausted everything I know about it in 3 minutes. Okay, so there's some additional concepts in your handout related to bias, and there's some additional discussion in this book if you are further interested in or need something to read on the plane. Let's talk a little bit about confounding. Okay, confounding deals with some variable that impacts either an independent or a dependent variable and alters the investigator's ability to determine the true effect on the outcome. That is, it may hide or it may exaggerate some association that we're looking for. The best way to avoid confounding is to collect as much relevant information as possible. And usually these deal with retrospective type designs in which we're kind of restricted by the instrument that we've collected data from. We can control for confounding based on the design of a study, obviously in a randomized controlled trial. That's the most effective way to control for confounding. But we may also be able to do it in stratification, or we may be able to do it after the fact with multivariate analysis. But in order to do those multivariate analyses, we have to have sufficient data to allow us to investigate those factors that may influence the analyses. Okay, we're going to spend the next 20 or so minutes talking about different types or the hierarchy of study designs. And I think many of you have probably seen a pyramid such as this, in which the different types of study designs are shown. Ideas, opinions, and reviews are shown on the bottom. And a common example of this, I'm going to harass my wife, and she's here in the hotel, but I don't think she's actually here in the room. But I know my friend and boss will probably tell her that I harassed her, but that's okay. So my wife thinks vitamins are the greatest thing ever. Okay? We should use them for everything. And most evidence suggests that that's not true. If you go through the cardiovascular literature, you know, vitamin C does this and vitamin E does this, and they do really nothing. Okay? Even though we have, this is not a vitamin talk, so I'll stop there. So that's an idea or an opinion, right? That's my wife's opinion, which isn't based on any literature. And there's lots of physicians out there, and lots of pharmacists and lots of nurses who share lots of opinions based on a variety of different things, and they're exactly that, they're opinions. One kind of rung higher than that is a case series, okay, or a case report. Case reports, N of 1, case series, an N of 2 or 3 or 4 or 5, depending on how many things we observe. Observational studies here in the middle, cross-sectional, case control, cohort studies, we'll talk about these to some extent, and randomized controlled trials, of course, are in terms of the hierarchy, towards the top, and then systematic reviews and meta-analyses are shown at the top of this pyramid. Remember that clinical study designs can employ prospective and retrospective designs, and we'll talk more about this in a second. There is one common misconception that I want to bring to your attention, and that is that there's sometimes the misconception is that only case control studies are retrospective. Cohort studies can be retrospective. So case control studies are not the only trials that are retrospective. So again, let's talk a little bit more about case reports and case series, ask some questions, and then move on to other observational studies. These obviously document and describe experiences, novel treatment, and unusual events. Sometimes in those situations in which study is not possible. Okay, perhaps a rare condition or what have you, we don't have the ability to perform a study. An example of a situation in which a case report, and there's countless examples of this, obviously, was really the first to report something in the literature is QT interval prolongation associated with fluoroquinolone antibiotics. Much of the literature, the start of the literature in this case, was based on case reports and case series describing these events in patients. Again, case report is 1, case series is 2, or is greater than 1. The most important thing to evaluate when evaluating these types of studies is whether or not there's sufficient detail in the methods to draw conclusions outside of that particular situation. A common question that I get asked is from clinical pharmacists in the field who are perhaps have a case report that they'd like to publish or what have you, is IRB approval required for case reports? Our IRB at the Indiana University Medical Center recommends that if it's possible, then it's in your best interest to submit for IRB approval for a case report, and I think certainly a case series. It's almost always a very expedited process, doesn't involve a full application. And so I would always say that yes, it would be a good idea to do that. Is it required by federal statute? I think if you read the letter of the Federal Register that deals with this aspect, probably not. but it's, I think, in your best interest and safety for that to happen. The advantages, the disadvantages of case reports and case series are obvious. The advantages, again, in some situations, we don't have the ability to conduct a study due to either a rare condition or other situations, such as the ethical nature of conducting such a study. So in these cases, case reports and case series can be valuable. Let's go through the observational study designs now, first starting with case control studies, cohort studies, and cross-sectional studies. I think the point to highlight the most in this particular situation is that the designs of these studies does not involve an investigator intervention, only an observation. And because of that, observational study designs investigate association, not causation. Okay, so observational study designs investigate association, not causation. And these concepts are, I think, a testable situation in which you're asked to draw some conclusions about a result from an observational trial and whether or not it's a cause and effect situation. So again, association, not causation. Let's look at a case control study first. And all I want to highlight from this slide is that the case control study studies exposures in those with or without a condition of interest. So we want to determine the association between exposures or risks and disease or conditions. And the classic example in the biomedical literature is the association of aspirin use and Reye's syndrome. I know this is an old study, but it's still highlighted as a classic case control study in which the observation or the association between aspirin use and Reye's syndrome was elucidated. It's often referred to as retrospective studies. We've already said that we could also have a retrospective cohort study. So they're not the only types of retrospective trials. These studies are most useful in studying exposures in rare diseases or ones that take a long time to develop, in which it would be cost prohibitive to do a cohort study because of the amount of time that it would take for that study to be conducted. Some critical assumptions related to case control studies in an effort to minimize bias. One is that cases are selected to be representative of those who have the disease. And controls are representative of the population without the disease, but they're as identical, doesn't make a lot of sense, but as close in identity to the cases as possible. And information must be collected in cases and controls in the same manner in an effort to minimize bias. There's an example that we'll go through a little bit later, which is a phenylpropanolamine study and its risk of the causation, and its risk, causation's the wrong word, and its risk associated with hemorrhagic stroke. Advantages of case control studies, they're inexpensive, they can be conducted fairly quickly. They allow the investigation of multiple potential exposures or associations. The disadvantages is that we have to control for confounding as best we can, and usually this happens by statistical manipulation or statistical methods. Observational and recall bias is sometimes challenging because we're potentially asking individuals who are enrolled in this trial what happened to them a year ago, 5 years ago, 10 years ago, what have you. The measure of association in this particular type of study is the odds ratio. Okay, and it's usually then an estimate of the relative risk that we'll talk about for cohort studies. So the measure of association is, for a case control study, the odds ratio. So let's switch gears from a case control to the next kind of notch in terms of observational study designs and look at a cohort study. Cohort studies determine the association between exposures or factors, and disease development. Okay, so now we're incorporating some time sequence in this particular factor and evaluating this in a cohort study. The relative risk in this case is the measure of interest, and we study the outcome of interest in those with or without exposure. The classic example of a cohort study is the so-called Framingham study, a study that took place in Framingham, Massachusetts, in which a cohort of individuals from that village in New England was followed over time. In this case, still being followed over time. Started in the 1950s, I think, and we're still following that cohort or the offspring of that cohort over time. So the cohort study describes the incidence or natural history of a disease or condition and measures it in time sequence. Different than a case control study and different than the next observational design that we'll discuss. So retrospective, this can be done retrospectively or prospectively. Retrospectively means that it begins and ends in the present, but we have to look back to collect the information. The advantages here is that it's cheap. Okay, it's not quite as time consuming. There's no loss to follow-up because we have all the data that we're going to collect. The disadvantages is it's only as good as the data that's available to us, and confounding frequently comes into play in these types of studies because we can't collect additional data. We're dealing with the information that was collected as part of that cohort already. And so we have to control these confounding variables with statistical approaches. Prospective, on the other hand, begins in the present and progresses forward. Just like the Framingham cohort, we start the study today and we're collecting information as time goes on. The advantage is it's much easier to control for these confounding factors. It's easier to plan for data collection because we're collecting data in the future. The disadvantages, hopefully, are self-explanatory. It can be incredibly expensive, incredibly time intensive. There's loss to follow-up. You know, individuals, again, from Framingham who left Framingham were in many cases lost to follow-up. And it's very difficult to study rare diseases or conditions at a reasonable cost because the number of people that are required is so large. Lastly, in terms of observational study designs, the cross-sectional or the prevalence trial, probably the easiest of this group. We're basically taking a snapshot in time, okay, and assessing the prevalence or characteristics of a condition in a group of individuals today or in a month's period of time or what have you. I've listed an example here, a cross-sectional analysis from a study. This is easy design or easiest design. Data is only collected at one time. Okay, and it's usually accomplished by a questionnaire or an interview or some other available information. The disadvantage is time is not a factor. We can't study the progression of this condition over time. And again, it's very difficult to study rare conditions because of the large sample sizes that are required. Two concepts that are related to these types of designs are incidence and prevalence. Just to remind you that that incidence is a measure of the probability of developing a disease. Okay, incident rate would be the number of new diseases or cases of disease per population in a specific amount of time or a specified time, and these concepts are typically measured in persons per year. Prevalence, on the other hand, is a measure of the number of individuals who have a disease or condition at any given time, today or in the month of April 2013. Okay, so point prevalence would be today. Period prevalence would be in a year's time or in a month's time. Okay, so let's spend some time talking about evaluating or interpreting relative risks or odds ratios. There were a couple of questions during the break about interpreting confidence intervals, and hopefully these will clear up some of these questions. Again, key point for these types of studies that we've discussed that are reporting relative risk or odds ratios, this is probably the fourth or fifth time that I've said this, these are not cause and effect. We're assessing association. Remember, relative risks, also known as risk ratios, cohort studies, odds ratios, case control studies. The relative risk and odds ratios are interpreted on the basis of their difference from 1. Okay, so if we have a relative risk of 1, the numerator and the denominator, or the risk in the numerator and the risk in the denominator is the same. So there would be no difference between the numerator and the denominator, or no difference between the two groups that we're investigating. So if the 95% confidence interval for that relative risk or odds ratio includes 1, then we would conclude that no statistical significant difference exists. Okay, so in this case, again, relative risk and odds ratios are interpreted on the basis of their difference from 1, where 1 means the risk is the same. 95% confidence intervals that include 1 mean no statistically significant difference. And we'll go through some examples of these, hopefully, to make it a little bit clearer. So let's focus on interpreting the index of risk, and we'll start here on the top. Either for odds ratio or relative risk, and their meaning differs a little bit. But from the concept of where 1 is versus what the value is, the general meaning is the same. So relative risk or an odds ratio of less than 1 means there's a negative association between what we're investigating. Equal to 1 obviously means that there's no association, there's no increased risk. Or in the case of an odds ratio, the odds of exposure is the same in the two things being assessed. Whereas a relative risk or an odds ratio greater than 1 implies a positive association. From the sake of a relative risk, it means that the risk is greater in the exposed group, or in the case of an odds ratio, the odds of exposure is greater in the disease group. In terms of the magnitude of risk, again, I think a highly testable concept is to understand what that relative risk and odds ratio means. Relative risk or odds ratio of 0.75 basically it means that there's a 25% reduction in the risk or odds associated with that condition that we're studying. 1, of course, means no difference. Or 3 means there's a threefold or 200% increase in the risk or odds of that particular situation. So calculation of relative risk or odds ratios, I'm not certain. I wouldn't think you'd be asked to do this. But it's listed on your handout. I'm not going to go through this, except to say that there's relative risk and odds ratio is shown here. You can go through these calculations. Again, this is based on that phenylpropanolamine study that we'll talk about in a second. In fact, we'll talk about it right now. So let's focus only on the bottom piece of this table. And basically, what this investigation did back in 2000 was to investigate the relationship between PPA use, okay, and the development of stroke, which is shown here as the cases and/or controls in women, men, and in either of those two groups. And again, I just want to focus on the bottom piece of this. And this is not because we're focusing on the drugs, we're focusing on the estimated odds ratios from this study. And this is a case control study. Okay, and you can see that the reported assessment of odds is the adjusted odds ratio, so statistically adjusted for this particular analysis. So let's focus on the bottom part. Let's focus on the women first. Okay, so this is the risk of stroke. Okay, versus the risk of developing stroke versus not developed stroke in women, and you can see that there's almost a twofold increase in that odds, okay, but not statistically significant, right? Because that confidence interval, this is the odds ratio, and the 95% confidence interval includes 1. All right, so that first situation, PPA in women, no statistically significant increase in that odds ratio, even though it's twofold greater than 1. Okay, in men, the odds ratio is a little bit less than 1, but again, since that confidence interval includes 1, that's also a non-statistically significant finding. And finally, if we compare the two groups, obviously, if you compare these two, you'll see that obviously this 1.49 is somewhere in between 1.98 and 0.62. Again, no statistically significant increase in odds in that particular situation. Now, if you go up to the top of that table, you'll see that these two odds ratios, 16.6, with a huge confidence interval, suggesting a large variability in that data set, does not include 1, nor does this include 1, suggesting that those are statistically significant findings. Okay? So interpretation of odds ratios in this particular case. Just to kind of summarize for the 6th time, remember that observational studies describe associations and not causality, but they're also what we like to refer to as hypothesis-generating studies, that we might be able to determine or evaluate causality in a future study, but we can assess in those situations in which we aren't able to do a randomized controlled trial to assess causality directly. We may be able to, one, ask the question if statistical significance was observed. What's the strength of association? Okay, what was the odds ratio? Was it 1.5? Was it 2? Was it 3? The higher the odds ratio, generally speaking, the better the case that can be made for causality. Dose-response relationships. If our odds ratio goes up, 10 milligrams versus 20 milligrams versus 40 milligrams versus 80 milligrams, if there's a dose relationship between dose and odds, then perhaps that makes a better case for causality. And then there's a number of other factors. Perhaps there's an experimental animal study, in vitro study that suggests the same thing was observed outside the clinic. Then we may make a better case for causality. But in general, remember, observational study designs describe associations and not causation. I promise that's the last time I'll say that. Okay, this summarizes what we've just discussed, but reminding you that case reports, cross-sectional study, case control studies use odds ratios, cohort studies use relative risks, and cross-sectional studies generally prevalence. And the major advantages and disadvantages are highlighted there, and anyone who wants to read further, you can see that the reference at the bottom of this page describes a pharmacotherapy review article that goes through this. There's also 2 other papers in this same, not in the same journal, but there's a sequence of 3 papers in pharmacotherapy in this time frame that are very good reviews of statistics. Not only observational study designs, but also some basic reviews of statistics that I would encourage you to look at if you need to or want to. Want is a strong word. All right, let's shift gears now to randomized controlled trials. So obviously, randomized controlled trials allow the investigator to make an intervention and then to evaluate cause and effect from that intervention. So the design allows us to assess causality. And for the most part, minimizes bias through randomization and or stratification. So this would be our ideal study design in those situations in which it's possible to do. Two types of randomized controlled trials: parallel group design and a crossover group design. Remember that crossover design studies provide both practical and statistical efficiency. So in a crossover design, individual group of subjects receives one therapy and then is crossed over after some washout period to a second treatment, okay, and maybe crossed over again to a third treatment, what have you. So that provides more statistical and practical efficiency as it reduces variability. Because we're studying the same person, each person's receiving the same treatment or receiving each of the treatments. As opposed to a parallel design in which we have one group that receives drug X, we have another group that receives drug Y, or what have you. So there are certain situations, though, where crossover designs is not appropriate. Consider diseases that change over time. A common disease that I'm familiar with in terms of literature that I read, heart failure, changes with time, right? Patients worsen, sometimes very quickly, in which case a crossover design study may not be appropriate and is typically not employed in this particular situation, because by the time we cross that subject over to the second therapy, their disease is worsening. Okay, so in heart failure, typically parallel design studies are the ones that are employed in that particular situation. Some examples, there's obviously endless examples of clinical trials, and you can read about these, but we tend to think of the clinical trial piece more often than there's also educational interventions, an online course versus a lecture course format in terms of evaluating how students learn in that particular situation. We could do the same for this live course versus the recorded version that's going to be available at some point in order to draw conclusions about how effective learning was in that situation. There's healthcare interventions, pharmacist-based teams versus non-pharmacist-based teams, and then looking at patient outcomes would be another example of randomized controlled trials. Obviously, there's lots of questions that we want to ask about randomized controlled trials. Are the results of the study valid? Can I apply this to my patient population? Will they help me take care of my patients? Internal validity versus external validity types of questions. I want to spend some time focusing on some issues related to randomized controlled trials, subgroup analyses, primary, composite, and surrogate endpoints, and then superiority, equivalence, noninferiority 101. Okay, again, we could spend months talking about these types of studies, and I'll direct you towards some additional information if you desire some. So let's first start at subgroup analyses. And I think these are very testable concepts in terms of examinations of this sort to have you work through cases and make decisions about different types of analyses that may have been conducted in a study. Obviously, subgroup analyses are an important piece or an important part of controlled clinical trials, but yet they're often underused and often overinterpreted. There's lots of pitfalls. One, and probably the most common, is the failure to adjust for multiple comparisons and adjust p-values. Remember, for each, if we have an alpha value of 0.05 when we start a study, if we make 100 tests, 5 of them are going to occur by chance alone. Okay? So we want to minimize the number of tests that we make. We want to make sure, a priori, we decide which comparisons we're going to make. And if we make substantially large number of comparisons, we want to make sure that adjustments in p-values, Bonferroni correction is one of them, would be undertaken in these particular situations. Subgroup analyses also cause problems in terms of sample size, power. Seldomly are subgroup analyses thought of in the design of a trial in terms of how we estimate the number of subjects that we'll need. That's almost always the primary and perhaps a secondary endpoint, but not these small subgroup analyses. Primary and composite endpoints. Okay, the primary endpoint is obviously the crucial design decision that's made by an investigator. And the power of a study and the sample size for that study is based on that particular primary endpoint. But I want to read through a statement from the HOPE trial, which was published, a bunch of years ago now. But tell me if you can understand it, because I've read this probably 15 times, and I've struggled to figure out what the investigators actually mean. So they say that ramipril reduces the rate of death, MI, stroke, revascularization, cardiac arrest, heart failure, complications related to diabetes, and new cases of diabetes in patients. What does that mean? Does it mean ramipril reduces the rate of death and reduces the rate of MI and reduces the rate of stroke? Or is it all these things combined? And how do we make decisions clinically if we don't know what things are being assessed? Okay, so questions that we need to ask: is there a reduction in all these endpoints or just the combination? And many times investigators don't clearly delineate that. Are all the outcomes just as likely to occur? And why would this trial have been interested in all of these outcomes? Well, this was a study in high-risk patients with vascular disease. And so obviously these are a number of different factors that can be assessed in these particular patients. Composite endpoints. So why are composite endpoints such as this used? Well, they're used because they reduce the number of subjects that we need. Okay, if we can assess if we can capture mortality, we can capture heart failure, we can capture MI, we can capture diabetes, then we have more events, and so our sample sizes and the cost of sample sizes go down and the cost of trials goes down. But there's lots of factors that are important. We don't always know how to interpret those composite endpoints. Okay, we don't know which ones are there dilutions of effects. That is, do some of these average each other out or subtract the benefit or detriment of others, resulting in this kind of averaging in overall effect. Some have suggested perhaps that composite endpoints, perhaps with death, weighting more than MI, weighting more than some other adverse event may be a better approach. Needless to say, results of each of the individual endpoints are essential for us to evaluate the results of that composite endpoint. Surrogate endpoints introduce their own problems. There are 3 examples here of different surrogate outcomes or surrogate endpoints that have been measured in clinical trials. The first, again, fairly widely appreciated, that if we reduce blood pressure, we reduce stroke. Okay, if we reduce LDL, most people would surmise that we'd reduce cardiovascular death. There's actually two examples, though. We know that's clearly true with statins. If we reduce LDL, reduce cardiovascular death. But hormone replacement therapy is a pretty effective means to reduce LDL cholesterol as well, but we know that that does not reduce cardiovascular death. Perhaps the biggest example, and I may be dating myself here, is the PVC suppression hypothesis. The CASS trial in the late 1980s suggested that that while antiarrhythmic drugs are pretty potent PVC suppressors, that was not associated with mortality reduction and in fact associated with an increased risk of proarrhythmia. So we have to be very careful when we look at surrogate endpoints and the smattering of information that may result from that. And we should remember that surrogate outcomes don't predict clinical outcomes. This is especially true in short duration studies. You know, cholesterol studies are pretty common examples of this, where it's sometimes these studies are too small or too short to detect uncommon adverse events. Okay, there's only one slide that's devoted to superiority versus equivalence versus non-inferiority trials. I would recommend that there's a whole slew of literature on this. Those 3 papers from Pharmacotherapy focus on this a little bit. There's also an editorial in Pharmacotherapy written by Lee Vermeulen from the University of Wisconsin a couple of years ago that focuses on non-inferiority trials specifically. But I think this kind of summarizes perhaps the concepts to take into an exam with you in terms of evaluating these. So superiority trials, this is our typical long-standing clinical trial that's designed to detect a difference between treatments. 2 treatments, 3 treatments, 4 treatments, what have you. Equivalence trial, on the other hand, is designed to confirm an absence of a meaningful difference between treatments. Okay, and the first kind of thing that comes to my mind, again, based on the literature that I typically read, is if you remember back when new thrombolytic agents were coming to market, new agents were compared with TPA, basically to determine whether or not we could confirm a meaningful absence of a meaningful difference between those therapies and conclude that we could use either one. Well, over the past 10 years, of course, there's been this explosion in non-inferiority trials, and I think that the thing that makes it confusing is there's a lot of statistics that goes into non-inferiority trials in terms of the design and interpretation of these types of studies. But basically what we're trying to do here is to investigate whether a treatment is not clinically worse than one that's been shown to be effective. Okay? We'll talk about in the next slide one of these types of designs. And in this particular situation, it's useful in this setting when placebo is not possible because of ethical reasons. So we can't do a placebo-controlled trial. So instead, we're doing a non-inferiority design. So the example of this is a study called the On-Target trial, which was a study of telmisartan versus ramipril or its combination in patients with a high risk of cardiovascular or vascular disease. And basically the question that was asked was, is telmisartan non-inferior in the incidence of cardiovascular deaths? And the investigators set this non-inferior difference, define it as less than 13%. Okay, so this is the crucial piece of this design that you have to interpret. Is this 13% a reasonable number? Okay, and that obviously takes some understanding in terms of the history of that disease, the previous trials. The essentials of a non-inferiority design are that, one, the control group, in this case ramipril, must be effective. And there must be a study similar to this study, okay, that showed that particular agent was effective and that the doses are equal to what's being studied in this particular study, that the clinical conditions and that the design is as close as possible as the current design. Now, what sometimes happens is so-called non-inferiority design drift. So that as you go down the line from ramipril to telmisartan, and now the next study with some new drug and the next study with some new drug, there's some drift that happens in the interpretation and the statistics of these studies that makes it more complicated to evaluate these non-inferiority designs. But if you have some extra time, Lieber-Muellen's paper is really good in trying to describe those concepts. And again, it's in Pharmacotherapy in the past 3 years or so. Adequate power in these types of studies is essential, and typically larger sample sizes are required in this particular situation. So let's go through some examples of a randomized trial and talk about some of the statistics, try to put together the first session with the second session, and talk about some aspects of this study. So I present, this not for clinical reasons, but for statistics reasons, and it's a trial that I'm certain everybody perhaps has read or certainly at least heard about. A randomized trial of estrogen replacement therapy for secondary prevention of CAD in postmenopausal women. And the objective of this trial was to assess whether or not estrogen replacement therapy alters the risk of CHD in postmenopausal women. The doses and such are not necessarily important, but obviously this was a fairly large trial with long follow-up, 4.1 years, with a substantial number of individuals taking drug at the end of both 1 year and 3. The endpoints in this particular study were the risk of non-fatal MI and CHD death. Okay, 2 pretty common endpoints in this type of study. There are lots of secondary endpoints, including all-cause mortality. Okay, and all-cause mortality most likely became a secondary endpoint in this particular situation in an effort to try to maximize sample size, because all-cause mortality would have taken considerably larger numbers of subjects and longer periods of time. There was, of course, a surrogate endpoint, which is, I think, an important concept in this study, maybe one of the most important concepts in this study, and the relationship between that surrogate endpoint and the actual clinical endpoint that was observed. Baseline characteristics were compared with a t-test and a chi-square. Power analysis was conducted, and sample size calculations were done, and Kaplan-Meier curves with Cox proportional hazards model and intention-to-treat analysis was used. So we'll go through these, and for the remainder of the presentation, highlight some of the other factors related to intention to treat and what have you. Okay, so baseline characteristics in this study, again, we kind of hit on this in the first 90 minutes of the presentation. I'm just going to hit on it again because I think it's important to reinforce these concepts, because these are probably the 2 tests that you're going to see most commonly used. So here's baseline demographics, age, percentage of Caucasians, as well as educational status and years in the ERT group, as well as the placebo group, and the placebo group, the p-values are shown in the last column. So I won't ask you these questions, but think about which ones you would answer. So in terms of age, comparing estrogen replacement therapy group versus the placebo group, hopefully everyone would answer green, okay, for t-test. Age is continuous, and as best we can tell, normally distributed. Now, how can we tell whether or not these values of age are normally distributed or not? How would I approach this situation from a statistics standpoint? Well, I would usually cheat, okay? That means I would use a t-test, and I would use a non-parametric equivalent of a t-test in this situation, compare the results, and if the results are similar, then I'll use the parametric test. Okay? But how else could you look at these data and make some conclusions about whether or not we think this is normally distributed? So remember, back to the first session, we talked about the empirical rule. All right? So the empirical rule tells us that 67% of individuals fall within 60 and 74 years of age. All right? 95% of subjects fall between 53 and, if I'm doing my math correctly, 81 years of age. Okay, and I would probably stop there and say, does that look like what the inclusion and exclusion criteria in terms of age was for an enrollment in this trial? And, you know, for lack of a better way, I think it does. Okay, we don't have standard deviations that are 67 plus or minus 30, in which case we'd have a range in age from 37 to 97. I don't think that would probably fit the criteria for a normal distribution. So in this case, t-test, the only option you had was t-test and chi-square. So t-test is the most appropriate situation. The same is true for educational age, or excuse me, educational status. That would also be compared with the t-test. And that gives the answer away to the percentage of Caucasians. That would be compared between the two groups with a chi-square. Okay, 88% versus 90%. Now, hopefully, you can look at these data and say, I wouldn't predict there'd be any statistically significant differences between these groups. All right. One, I'm going to maybe go off on a little bit of a tangent here, more from a practical standpoint as opposed to something that you might see in an exam, but is it necessary, remember this is a randomized, controlled clinical trial, is it necessary to show p-values for this comparison? There's another pharmacotherapy paper that deals with this issue, and the answer is no. Okay? Why? Because this is a randomized trial. Okay? So randomization should take care of any differences that exist between baseline characteristics. And if we see differences, then we better be careful. We better be pretty concerned about what our randomization procedure is. Okay? So actually, comparisons between baseline demographics aren't required in these types of studies, in randomized controlled trials that are sufficiently large and appropriately randomized. Now, for observational trials, always we want to be comparing baseline demographics because we don't have any randomization procedure in those types of studies. But there are lots of editorials that deal with these kinds of issues. Again, one in Pharmacotherapy not too long ago. All right, there's another question, and something that you'll come across commonly in clinical trials is there'll be a statistical test reported, like there'll be a p-value reported here, but no mention of any tests that would have been done to compare these. Okay, so we need to assess whether or not, or what would have been done, and did we think it was appropriate. Okay, so let's focus first, and I'm not really sure what this p-value is for. Is this gold bar, is the constant, or is the LDL change here different from baseline, or is it gold different from green? I don't know what the case is, and the authors never tell us. So we'll talk about each of those factors and what would have been compared. So if we want to know, was there a difference between the two groups? That is gold different from green? What statistical test would we use? Anybody brave in the audience? We simply want to compare this gold bar, the average, versus green bar, the average. So it would be an unpaired t-test, two-sample t-test, independent samples t-test, or whatever you want to call it. But what if we wanted to know, did estrogen replacement therapy reduce LDL concentrations versus baseline? Okay, so we want to compare this with the baseline value. Then what test would we use? Then we'd use a paired t-test. Okay? So if we're comparing the two groups are independent. There's estrogen replacement therapy versus placebo. We'd use a two-sample test, which is what was used in this particular situation. And the same is true. These are all statistically different between green and gold. Remember this result as we go to, again, many of you I know have seen this trial, but remember this result in terms of surrogate endpoints. Obviously, there's a substantial reduction in LDL cholesterol, not as much as a statin would reduce, but still a pretty substantial reduction in LDL cholesterol, and we'll see the clinical endpoints in just a second. Okay, I've already done that. So let's go to the composite endpoint, primary CHD events, CHD death, any thromboembolic event, gallbladder disease. And again, I've kind of picked and choose as I wanted to make a variety of points. So hazard ratio in this point for primary CHD events, I think you can see the percentage of individuals in the estrogen replacement therapy group, pretty similar to the placebo group in terms of events. And the hazard ratio is pretty close to 1, and 1 is included in the confidence interval in this case. So no statistically significant difference between estrogen replacement therapy and placebo. The same is true for CHD death, although there looks to be a slight increase, 5.1 versus 4.2, between estrogen replacement therapy and placebo. Some people may use the dreaded word a trend. I'm not sure what that means. It's either there isn't or there is. Okay, in this case, there isn't, because even though there's a small increase in the hazard ratio, that's not statistically different from 1. And if we do stats, then we need to use the conclusions that those statistics provide for us. Lastly, and the result from this trial that was the most talked about, or one of them that was talked about, was the fact that there was a threefold increase in any thromboembolic event in the estrogen replacement therapy group as compared to placebo. The hazard ratio is 3, and you can see that the confidence interval does not include 1, so that this would be a statistically significant finding. What about gallbladder disease? Is that statistically significant? No, but it's pretty darn close, right? The p-value for that comparison would be equal to 0.05. All right, exactly 0.05. Again, a small increase, but not statistically significant. Okay, so let's go through some common approaches for analyzing clinical trials. Talk about intention to treat, talk about per protocol analysis, and we'll talk about actual treatment analysis. Intention to treat analysis is the most commonly used, and likely, if you talk to statisticians, the most statistically conservative approach for analyzing randomized controlled trials. And basically, they are analyzed as the subjects were intended to be treated based on the protocol, based on the randomization. Okay? And most statisticians will tell you that the treatment effects that we observed closely mimic usual conditions that we would see in the clinic. Okay? That this is analogous to routine clinical practice. The example is in which a subject, in clinical practice, a patient receives a drug that they don't take. The intention to treat analysis is basically handling that situation in the same way. So this provides a conservative estimate and usually underestimates the differences that it may exist between the treatments that are being compared. And it's, again, the most common approach to addressing clinical trial results and probably the most conservative statistical approach. Contrast that with per protocol analysis, in which those who do not complete or adhere to treatment are not included in the final analysis. Okay, usually if a clinical trial is going to use a per protocol analysis, they will have also done an intent to treat analysis because we're ignoring randomization in this particular situation a little bit. But these particular analyses may provide additional information about treatment effectiveness and may actually provide more generous estimates of the differences that exist between the two groups that we're comparing. There's obviously, we're subject to now lower sample sizes because we're just throwing people out if they don't take the particular drug. And it requires very detailed descriptions of what adherence and non-adherence to the treatment that's being employed is. And obviously these results are a little bit more difficult to interpret statistically than a typical intention to treat analysis. And lastly, the most willy-nilly approach is actual treatment analysis. And that is, we basically threw out the whole randomization procedure and analyze people based on the actual intervention that they received. So if they were initially enrolled in the treatment group but didn't take the treatment, then they're analyzed as if they were in the placebo group. Obviously, statistically, this presents lots of problems, ignores the randomization process in those who do not adhere to the study design. So this particular type of analysis should be discouraged. Okay, moving on to systematic reviews. In terms of the hierarchy of design, we're at the tip of the pyramid, so to speak. But these types of studies, just like randomized controlled trials, really need people such as yourselves, when you're analyzing these trials, to think long and hard about what their inclusion-exclusion criteria were, and we'll talk about that when we get to meta-analyses. So basically, systematic reviews are a summary that uses explicit methods, inclusion-exclusion criteria, etc., to perform a comprehensive literature review and then critically appraise it and synthesize the literature. And it differs from a standard review article because of the methodology that's used in the comprehensive consolidation of these papers. The key is well-documented and described literature review. Some systematic reviews go on statistically. We'll talk about that in a second, to statistically combine results from many studies. A systematic review by itself doesn't do that statistically. A meta-analysis, which we'll talk about in a second, does that. And we've already talked about this last bullet point. So meta-analyses, on the other hand, are systematic reviews, okay, that use statistical techniques to summarize and combine the results of the evaluated studies. And these techniques may improve upon a larger effect size, increase power because we're increasing the number of subjects that now we're including in these results. They may allow the interpretation of disparate results from one study versus another study, or hopefully 10 studies versus 12 studies. And in that regard may reduce bias. But they may also allow us to answer questions that we couldn't address in a randomized trial, because we can't conduct another trial, say, evaluating digoxin's use in heart failure, because it's been done 6 times and et cetera. So it may allow for answering questions that we can't answer with additional study. I think the most important point of meta-analyses is that just like randomized trials, we need to evaluate the inclusion and exclusion criteria for these types of studies, as well as the statistical methods, to ensure validity. Now, I say that, and most meta-analyses use incredibly complicated statistical analyses that we don't really talk about in these courses or in basic stats courses. and are usually accomplished by statisticians. So it's sometimes very difficult to analyze those types of designs. So we need to ask if there's a focused research question or if it's a fishing expedition. We need to look at what types of studies were included. How were they included, excluded? How was the quality of those papers assessed? And were there multiple reviewers for each of the studies? How was statistical heterogeneity assessed? And this is typically done with chi-square or Cochrane Q tests, which would evaluate whether or not there was homogeneity among the studies. That is, were the studies statistically similar such that they're able to be combined? Lastly, sensitivity analyses and assessment of risk. Assessment of risk will depend on what types of studies are combined, whether it's case control, whether it's cohort, whether it's randomized controlled trials. All right, we're going to switch gears now and kind of talk about a smattering of small topics that I think you might see on an exam, at least to refresh your memory. And we're not going to exhaustively review these. We're just going to hit on, I think there's 3 or so topics left to just hit on some basic things that I think would be good for you to review. So first is this concept of summary measures of effect. And these started to, in the past 15 years or so, number needed to treat, absolute differences, relative differences kind of have taken the forefront in terms of clinical trials. So remember, absolute differences would be the absolute difference between a group versus a treatment group, versus relative differences, typically a percentage change between two groups, and absolute differences are always smaller than relative differences. Okay, and we'll look at some pictures of that in a second. Absolute differences are more important than relative differences. Okay, authors like to highlight differences in their trials with relative differences, and I fall prey to this as well because they're bigger. And you see a 50% reduction, even though it goes from 2 to 1. It looks a lot better when it's 50% versus that 2 to 1 change or 1%. Most drug advertisements, both directly to patients, especially directly to patients as well as healthcare providers, focus on relative differences as compared to absolute differences because they're a lot more fun. They look a lot better. So let's look at the HOPE trial again. Going back to the HOPE trial, this is a randomized, double-blind, placebo-controlled trial of about 9,300 patients at high risk for vascular disease who receive ramipril or placebo daily for an average follow-up of 5 years. And the primary outcome of this study was the composite of myocardial infarction, stroke, or death from cardiovascular causes. And here's the primary endpoint, the risk reduction. You can see here the proportion of patients shown on the y-axis who developed this primary endpoint over time, and the placebo group shown in blue, and the ramipril group shown in green. So every investigator, of course, wants to highlight that there's a 22% reduction in risk associated with ramipril as compared to placebo. Okay? In fact, that was a 4% absolute risk reduction, even though this big green bar seems to indicate a much more important reduction in risk. So we always want to look at both the absolute risk reduction as well as the relative risk reduction before we make conclusions about the importance of a clinical trial. Number needed to treat is a means by which we take into account the absolute risk reduction. And I would guess that in every one of these exams in the past 10 or so years, this has been tested. Okay, I don't know that for sure. I only sat for one of these exams a long time ago. But I would guess that this concept is tested on a yearly basis. So remember that the definition, the number needed to treat is the reciprocal of the absolute risk reduction. Okay, and shown here again, it's rounded to the next highest number. We'll show a couple of examples of that in a second. It's applied to clinical outcomes with dichotomous data. And it assumes that the baseline risk is the same for all. Extrapolation beyond the study time duration shouldn't happen. And number needed to treat should only be provided for those situations in which a statistically significant finding is observed. A contrasting term to number needed to treat is number needed to harm, a concept that we won't show, but a related concept. So here's a number needed to treat application from the HOPE trial. I've shown this is the absolute risk reduction. Obviously written here, the important concept is this is written in decimal format, not in percent format. So in this situation, 26.3 was the number needed to treat for the combined endpoint, rounded up to 27. Shows the fact that we need to treat 27 people to observe a reduction of one of these combined events. Okay, you can go through this at home. The absolute risk reductions are shown, and the number needed to treat are shown for each of the different components of this combined endpoint. All right, last two topics, and I show you again because I think just to refresh your memory and jog your memory about things that could show up on an exam. And again, we're not going to spend a lot of time on this. Pharmacoeconomics, obviously related to the cost of a drug, therapy to healthcare systems and society. Identifies measures and compares consequences of pharmaceutical products or services. And the types of pharmacoeconomic analyses are shown here. First is cost minimization. Okay, and this would be when the outcome of interest is equal, we're trying to seek the lowest cost alternative. Cost-benefit analysis, that we're trying to find the greatest net benefit alternative. Cost-effectiveness analysis, and the outcome here is in clinical units, blood pressure reduction, etc. We're looking for the most cost-effective alternative. And then lastly, cost-utility analysis, where we're trying to find the greatest benefit alternative. Okay, so I think it'd be good to, those three pharmacotherapy papers go into this in a little bit more depth. I think it would be good to prepare for that particular concept. And lastly, sensitivity, specificity, and predictive values are, I think, a common testable type of concept, and I won't go through these. Just to remind you about sensitivity, specificity, positive predictive values, and negative predictive values.